research paper we'll be presenting is called Two Novel Insulin Receptor Gene Mutations in a Patient with Rabson-Mendenhall Syndrome, the first Korean case confirmed by biochemical and molecular evidence. The insulin receptor is a type of tyrosine kinase receptor which is structurally made up of two alpha and beta subunits each. The receptor is activated upon the binding of insulin to the alpha subunit, which induces autophosphorylation, and beta subunits is kinase activity. Its receptor is encoded by a gene called INSR. Mutations within this gene is responsible for the development of insulin resistance. This is where your own body becomes resistant to the actions of insulin. There are three types of insulin-resistant syndromes, known as Type A, leprechaunism, and Rabson-Mendenhall syndrome, also known as RMS. Type A is defined by marked insulin resistance, acanthosis nigricans, a type of skin lesion, hirsutism, excessive hairness in women, and some forms of polycystic ovary syndrome, which is a condition where a woman has small cysts on her ovaries. Leprechaunism is another insulin-resistant syndrome which results in severe hyperglycemia and hyperinsulinemia. These are conditions where there are excess levels of glucose and insulin, respectively, circulating in the blood. Clinical symptoms of this syndrome include acanthosis nigricans, hirsutism, bloated stomach, enlargement of genitalia, particularly in the male, abnormal facial appearance with elf-like features, and growth retardation. It is an aggressive syndrome, and patients afflicted with this syndrome die within the first years of their life. RMS is characterized by the severe resistance to insulin and is similar in its clinical symptoms to leprechaunism, which include acanthosis nigricans, growth retardation, high insulin levels, and overgrowth of the pineal gland. Patients afflicted with RMS do survive beyond their first birthday, however not without the development of constant hyperglycemia, which is then followed by diabetic ketoacidosis and then death. This paper presents the findings of the incidence of RMS in a Korean patient for the first time and reports two new mutations of INSR, which are confirmed by clinical, biochemical, and molecular findings.
Mutations on the INSR gene were first found in an 8-month-old Korean male showing physical abnormalities such as pigmentations on skin-folded areas. Neonatal screenings at 38 weeks of gestation appear to be normal, however, at 8 months old, there appear to be signs of the child being underweight and not within normal height range. Initial laboratory tests showed normal fasting glucose at 69 milligrams per deciliter. However, fasting levels seem to be severely elevated at 554.6 microinternational units per milliliter, and the C-peptide level also were elevated at 13.81 nanograms per milliliter. The C-peptides are connecting peptides, which are protein chains of 31 amino acids. The glycosylated hemoglobin HbA1c used for diagnosing diabetics appeared to be within normal range at 4.8%. Aspartate aminotransferase AST and alanine aminotransferase ALT both showed slight elevation at 51 and 49 universal units per milliliter respectively. An intravenous glucose tolerance test was performed to rule out insulin-resistant syndrome, which showed both the fasting glucose and the insulin level at normal ranges of 57 milligrams per deciliter and 3.7 microinternational units per milliliter respectively. After 2 minutes of the IV of glucose was attached to the male patient, it indicated that a rapid increase of glucose at 204 milligrams per deciliter and an extreme increase of the insulin level at 2,508 microinternational units per milliliter. The insulin level continued to increase to a maximum elevation level at 3,300 microinternational units per milliliter, indicating extreme hyperinsulinemia. The male glucose level were checked after a while, which were still elevated at 128 milligrams per deciliter with glycosuria. A low sugar diet and oral hypoglycemic agent of 250 milligrams per day of metformin were given as therapy. A hormone growth was later given due to poor height gain and the low insulin growth factor 1 of 14.3 nanograms per milliliter. The growth hormone was then stopped as it had minimal effect on the patient's condition. The patient then returned to hospital due to poor glycemic control, therefore additional metformin was given. Some physical features were improved, however, protrusion of lips, crowding of the teeth, and abnormal dentition were observed, but his developmental and neurological examination seemed to be normal. Recent lab tests showed the elevation insulin resistance level at 364.1 microinternational units per milliliter, C-peptide at 4.3 nanograms per milliliter, and a glycosylated hemoglobin at 7.6%, but he did not seem to be diabetic. His bone age fit chronologically with his age, however his dental age was advanced. The genetic defect was identified by a molecular genetic test of the INSR gene and insulin receptor. Genomic DNA was isolated from nucleosides using the Wizard Genomic DNA Purification Kit. Primers amplified all coding exons and their intronic sequence of the INSR gene were a polymerized chain reaction using a thermocycler. Direct sequencing was used using the same primer set and terminator cycle sequencing ready reaction kit on an ABI Prism genetic analyzer was used. As a result, two variations were identified, a C to A transversion of nucleotide position 19 in exon 1 and a G to A translation at nucleotide position 712 in exon 3, replacing glutamic acid with lysine at codon 238. Figure 2 shows a direct sequencing of the INSR gene in a male patient.
Leprechaunism and RMS are both autosomal recessive diseases with abnormal alleles for insulin receptors. Mutation in the INSR cause a spectrum of inherited insulin resistance syndrome, ranging from leprechaunisms in which afflicted children die in infancy to type A insulin resistance, usually evident after puberty. RMS has an intermediate phenotype. Cells from most patients with leprechaunism shows absence of severely impaired insulin binding to insulin receptor, whereas cells from patients with RMS retain some insulin binding capacity. There are two types of mutation, nonsense and missense. The insulin receptor for sequencing was performed to identify the mutation. Expression levels of the mature receptor were determined by lymphoblastoic cells from the affected subjects. In most cases, nonsense mutation caused leprechaunism phenotype by reduction of insulin binding activity. Missense mutation in the beta subunits are commonly associated with milder impairment of insulin bindings and milder phenotypes with prolonged survival and less diffeomorphism, so-called Ramsay-Mendel syndrome. Patients with leprechaunism has alpha subunit mutation or homozygosity in beta subunit mutation, which tend to predict a more severe clinical course. Most patients with type A syndrome had heterozygous mutation in beta subunit, which affect kinase activity and result in mild decrease in insulin binding capacity. Reported mutation of RMS located within an alpha subunit of INSR were homozygous mutation. The reported mutation of RMS located within the alpha subunit of the INSR gene were homozygous mutation, including progressive decline in insulin level, whereas reported mutation of RMS located within beta subunit of INSR gene were heterozygous mutations. The patients with leprechaunism came from congenital pedigree and was homozygous for missense mutation in the alpha subunit of insulin receptor. The other two patients were both compound heterozygote with a nonsense mutation in one allele of the insulin receptor gene and a missense mutation in the other allele. In patients with Ramsay-Mendel syndrome, the missense mutation substituted in the alpha subunit. As described, it reported that only missense mutation was within alpha subunit of INSR gene in RMS, and nonsense mutation in alpha subunit have only been found in leprechaunism. In conclusion, we report a case of two novel mutation in subunit of INSR, which is first case of RMS, where a nonsense mutation is located within the alpha subunit of the INSR.
In conclusion, the Korean child was revealed to be compound heterozygote. The first mutation showed to be positioned at nucleotide 19 exon 1, and the second mutation appeared in exon 3, positioned at nucleotide 712. These two novel mutations are known as the missense and nonsense mutations in the INSR gene. This confirmed that the child had the RMS syndrome.